we can talk a bit about personal experience. You want to talk about, for instance, personal experience with cabozantinib or ramucirumab, or if in your institution these trials were run, what's your experience with regorafenib and so on?
Right. I think you're getting at this tricky decision now that we have to identify which agents to use in second versus third, and in some cases even fourth line therapy now with so many drugs available. I think we haven't used ramucirumab much. It does not yet have an FDA label in the United States, but from my experience in clinical trials, it is generally a well-tolerated drug, though one notes in the trial data that there are a small number of patients that can have encephalopathy that needs to be carefully monitored, and as well as ascites or fluid retention. And I think right now the data is limited to Child-Pugh A and fit liver function patients. Is that your experience as well?
Yes. So, in fact, if I recall well, in the REACH trial at the beginning, Child A and B patients were accepted, but after a first watch to the adverse event related to particularly Child B patients in terms of encephalopathy, this indication was, or inclusion criteria was removed. And the adverse event of encephalopathy now is marginal in Child A patients. Still, you are saying 3.54% of the patients may experience that, which is acceptable for this type of drugs.
We have now more options for systemic therapies. When we are sitting in the tumor board, it's very good because we have a lot of arguments to say that we should stop local therapies and switch to systemic therapies. And in the past, I think we really have pushed the limits of local therapies to an extent which was not really good for the patient. And most of these patients during this treatment developed progressive liver disease and were no more candidates for systemic therapies. And at that time, we already had one drug available. Yeah? Now we have more drugs available, and what we are seeing from our clinical practice that we can sequence these patients. And when we look at the clinical trials, for example, from the RESOURCE study, it was a second-line trial with a selected population of patients, but nevertheless, when we look at the overall survival from beginning of first line, the median overall survival was 28 months, which is really impressive, or 26 months, which is really impressive. Yeah? And today we have seen data from the lenvatinib trial, and also in this trial, patients either with lenvatinib or sorafenib that received second-line therapy had a median overall survival of 20 and 17 months, which indicates if we sequence the treatment, survival of our patients will be better. And therefore, in the future, we really need to see that we stop local therapies as early as possible. We should, of course, use them if they are candidates for local therapies. But if they are no candidates for local therapies, or if they do not really respond well to these local therapies, we should switch to systemic therapies. And now we have options. We can decide a little bit depending on the patient. We can see whether the patient tolerates either drug and then switch to the other drug, which makes it really easier in the field. What is the best sequence? We don't know yet. Yeah? But and a lot will really depend on the label, so which drug we can use at which time point.
We have 2 checkpoint inhibitors and 5 targeted agents. So checkpoint inhibitors, I'd like to, first choice of treatment will be checkpoint inhibitors, because response rate is not so high, up to 20%. But once response is obtained, the response is durable, long-lasting, and OS should be better. But remaining 80%, no response is observed at the 3 months. Response is observed by 3 months. So at the time of 3 months, if there is no response, we switch to lenvatinib, because lenvatinib show a high response, and response correlates with a longer OS. So we choose lenvatinib, and then third line maybe ramucirumab we choose. Then after maybe cabozantinib or other agent.